Okay. Now, you've all spoken in detail about how the OCT has and the adaptive optics can help image the RNFL. And along with this, when the machine came sometime last year, I was quite excited, thinking that let's do some work on lamina curvosa and see what it can sort of get. So I went to Arvo last year thinking, see how many posters might be there on the lamina curvosa. I found that there were more than 30 or 40 of them. Most of them, of course, have been using integrated devices, and so that's a different ballgame altogether. Now, we all know that the lamina curvosa is a mesh-like structure present within the spinal canal of the optic nerve head, and the multiple pores that you see in them are actually areas through which the axons as well as the blood vessels pass into the optic nerve. And the collagenous beams and the pores seem to sort of disintegrate, as you can see in some of these images, from the time it is normal to the time it gets damaged, and that's where you actually see the excavation. So multiple methods of imaging the lamina curvosa have been done. Most of them have been initially, let's call it lab-based, where they've actually looked at various techniques like histological assessment and then finite modeling, then using second harmonic interference and 3D deformation analysis. So they've actually constructed models and then worked on it. Most of the work done initially from Claude Bourgoin's group and from Gerard's group have been with reconstructing a model on what they assume is primarily on animal eyes. So for the clinician, that was still a far-fetched thing and not available for regular use. But now with the CSLO and with the some of the OCTs and with the enhanced depth imaging, spectral domain OCT software and adaptive optics devices, that has actually changed. So one of the limitations of seeing the lamina curvosa are the structures that are there present, sort of preventing us from seeing, including the retina, the choroid, and the scleral canal, or as you may call it. Now, as you can see in these images, as the nerve gets damaged, or as there is focal and finally global loss of the nerve fiber layer, you actually get to see more of the curvosa. So what we're looking at initially is usually limited to the anterior surface. Obviously, you can't go further back, and even with many of the spectral domain OCTs, you can sort of image the anterior lamina curvosa surface. You can't go further back behind that. The spectral domain OCT images basically have been found to match histological sections, but again, as I mentioned earlier, only part of the anterior lamina curvosa surface is available, and you obviously can't see beyond the nerve, unilateral rim, or the scleral rim, or the vessels. Those are all sort of barriers because it's definitely an optical imaging device. With the enhanced depth imaging software available on the spectral domain OCTs, you get to see a bit beneath the unilateral rim. The resolution is definitely better, but there are the usual limitations of the OCT. So adaptive optics, the focus was to try and sort of get an in vivo, or say a histological view of the tissues that are there that we couldn't image earlier with the traditional OCTs. And Liang et al. First described this, and the idea was to try and reduce the effect of the wavefront distortions. Many of them have been incorporated, devices have been incorporated into available OCTs. Many of them are still sort of prototype models that are not commercially available. You can actually visualize collagenous plates of the lamina curvosa, and you can actually see the NFL passing through the pores in optic nerve head. The idea is to correct the ocular aberrations that would prevent you from seeing the structures more in detail. And the idea also is to increase the amount of light that would reach the detector. and improve obviously the resolution and the contrast. So couple of slides or posters rather which I saw and I thought were interesting at Arwood last year was using the EDI scans on the spectralis, where they could look at differences in the cup depth and the level of where the cup is, and they actually saw that there was a negative association between the cup depth and the prelaminar tissue thickness as was expected. All these sort of articles are obviously based on a small sample, and I think it was all many of them were lab-based OCTs which are not commercially available. Some of the resolutions on these are phenomenal, 47,000 A scans per second. They actually found that in this patient, in these group of patients they looked at, they found that the pore count was lesser as expected in glaucoma patients. And they looked at pore orality or shape, and they found that normal patients had more roundish, if you may call it that, pores, whereas the glaucoma patients had more sort of oval pores. And however, if you look at the pore areas, you don't see too much of a difference because there's definitely a certain amount of overlap to a certain extent, and that could be because of the fact that there were that many less patients. Somebody also looked at the glaucoma severity correlating with the lamina cribrosa depth and thickness, and found that the lamina cribrosa depth was and thickness were both correlated significantly, but not very strongly correlated with the mean deviation or the pattern standard deviation. So the device that we have, as has been mentioned by Dr. Rao and Dr. Satyadevi, is a standalone camera, not incorporated into a machine. It measures a very small area, 4x4 field, and it does registration averaging. But having said that, it's a very small area and makes it pretty difficult to reproduce taking images serially, maybe in the small area. So what we did was we imaged the lamina cribrosa. Initially we found it difficult to image the cribrosa, but what we did was we used the STOCT images, used the reference plane in that in terms of how deep you want to go with your active optics device, and then we went to that depth, and then we realized that we could easily image the lamina cribrosa from there on. So the reference plane was the anterior lamina cribrosa surface, and then from there you can go deeper in. So we looked at pore count, pore area, and pore shape. We took the images, used ImageJ, which is a freely available NIH software, and then we calculated the pore areas and the number of pores, and also the spacing between the pores. So if you look at it, there are islands here. So we actually saw islands these are normalized, and these are glaucomatized. Now, in terms of how reproducible this is and what we can infer from this, it remains to be seen. We looked at the maximum pore area in right eyes of the 15 patients each that we looked at, and we found that there was no real difference between those that had glaucoma, which is the group 2, group 1 compared to those who did not have glaucoma. And again, it could be because the numbers were small. The mean pore area seemed to be larger in those that had glaucoma compared to those who did not, but again, there's only a trend and there's no clear indicators here. So, with all the limitations of the commercial OCT, the idea would be to obviously enhance the source images, look at orality, look at index. However, these are all gross approximations. The current machine that we have has a small field of view and it zooms into regions of interest. So the problem with that is that whether we can reproduce that same region of interest the next time you want to look at a defect or see if it's gotten worse, it might be a little tricky, and it processes those images. So there are motion artifacts because the image takes a little longer than is acceptable, say with the current OCT devices to register. You realize that there are obvious motion artifacts, and a small motion artifact creates a large largely unusable sort of image. And then the peripheral retina cannot be imaged, and the acquisition times are kind of long right now. There are no clear fixation targets internally yet which are usable, and as I mentioned, field of use can be small. So using OCTs that are, say, with higher wavelengths than, say, 900 nanometers, which allows penetration all the way through the choroid, thereby reducing the susceptibility of images to water dispersion. In OCT imaging, which is less affected by cataract and allowing visualization below the neuroretinal rim, vessels and scleral rim, like the step source OCTs, might actually be the best way. And increasing the bandwidth. So one of the things that we have a problem with is the bandwidth of the OCTs. If they can improve that, that will definitely allow us better resolution and better depth. Gira et al. Have actually shown how they can actually take spectral domain OCT images and post-process them to get more resolution. So just like how you would do for a regular film. Thank you.